Good afternoon and welcome to my second presentation. The presentation is on the effect of the Labour Care Guide on emergency Caesarean section. It was an interrupted time series study conducted at Uganda Maternal University. All right, and so I hope I'm audible. So it was published in the Ethiopian Journal of Reproductive Health in 2025 July. So this is going to be okay, so that's going to be the outline. We're going to look at the backgrounds, the WHO Labour Care Guide, what and why, the objectives, methodology, study population, and the results, and a bit of the discussion and limitations of our study. So, just as a background, maternal mortality rates in Uganda, because this is where the setting of the study was, the maternal mortality ratio in Uganda is around 100 per 100. Surprising that their rates are almost half of ours for one reason or the other. As I alluded to yesterday again, most of the trouble happens in low middle income countries, particularly in sub-Saharan Africa, where 70% of maternal deaths occur. And the WHO made a statement some time back that the autonomous Caesarean section rate is around 10 to 15%. A rate below 5% indicates an inadequate access to emergency obstetric care, whereas rates above 15% are not associated with any reduction in maternal or neonatal benefits. But this statement was later somehow made lighter. In 2015 at a Congress in Brazil, they said we should not strive to achieve specific rates, but rather we should do Caesarean section when necessary for the benefits of maternal and newborn outcomes. Now, there is limited literature on Labour Care Guide adoption generally across the world because it's a new tool that was introduced recently, though we have a recent study that was published by Vogel et al., who was very instrumental in the development of the Labour Care Guide. It was a multi-step randomized control trial that was conducted in South Asia, and I think it was published late 2025, so you can check that online. Now, allow me to divulge a bit and give a brief overview of the evolution of the labor monitoring tools up to when we came up with the WHO Labour Care Guide. Now, we credit Professor Emanuel Friedman. I believe most of us, or all of us who practice obstetrics know about him. He was an American obstetrician and gynecologist. He was employed at a facility in New York in 1954. Most of us were not born by that time. His wife happened to be pregnant and she went into labor. But on that day that she went into labor, he was on duty at a different facility just in the same town. So he requested for duty to go and attend to his pregnant wife as a companion. But sadly, he was denied that off duty because there was no one to relieve him. So he had to remain in labor ward monitoring women in labor. Now, what happened because of frustrations, he kept noting down how those ladies that he was monitoring were dilating from one cervical examination to the next. And at the end of his shift after 24 hours, he realized that there was a funny pattern that was being followed by these ladies. And out of curiosity, by the way, may his soul rest in peace, he died last year. That's when Professor Friedman died, if you're not aware. So, out of curiosity, in 1954, he decided, together with others, to try and make this formal, and they monitored 600 women, primigravida, low-risk primigravida, in labor, and that gave birth to the famous Friedman curve. That was in 1954. It's amongst the oldest papers that are published in the American Journal of Obstetrics and Gynecology. Now, around 1978 or thereabouts, in Zimbabwe, Professor Friedman and Philpott decided to use this labor tool. But there was a challenge. Most of women in that locality were being managed at the peripheral rural facilities. And they wanted to look at a way in which those ladies could be identified early so that they are referred to the tertiary care facilities for advanced care. And they thought of coming up with two lines on the Friedman's graph, which were called the action and the alert line. Now, later on, in 1987, during the Safe Motherhood Conference in Nairobi, I believe that's where it was held, the WHO formally adopted the partograph as the labor monitoring tool of choice. Now, in the year 2000, remember the original curve had the latent phase of labor, then the active phase of labor, which was divided into the two phases that we know. The WHO decided to drop the latent phase of labor. So the modified WHO partograph was born in the year 2000. Now, around the year 2000, because we are scientists, one scientist in America questioned the science behind the labor care guide. He was called Zhang. And he decided to do an observation of a number of women in America, that were around 5,000 or 10,000 women. And he realized, actually, what we have traditionally called active phase of labor, that 4 centimeter marker was not applicable to women at that time. Actually, he realized most of them were were going to active phase when they got to around 5 to 6 centimeters. Out of that curiosity, him and others did a huge study in the USA in the year 2010 that constituted around 27,000 women. And out of their study, the definition of active phase of labor was redefined in the USA from 4 centimeters to 6 centimeters. So the WHO, of course, was observing, and the scientists and the expert, and they decided to commission a huge study that was called the BOLD study. That's better outcomes in labor difficulty. They wanted to come up with a tool that was referred to as the SELMA tool. This, I believe some of us know about it, the SELMA tool. So that BOLD study was conducted between 2013 and 2017. It was conducted in 2 countries, Nigeria and Uganda. But they looked at many aspects of labor, not just the labor monitoring tool and the progress of labor. And following the study, one of the principal researchers from that study was actually my supervisor in my EmMed, and that's why there was a lot of interest when it came to adoption of this tool in Uganda. Actually, I think we were the first facility in Africa to adopt this tool. So they came up with 53 recommendations that were further taken up by the WHO Guideline Development Group, which came up with the 2018 Intrapartum Care Guidelines, and that's how the labor care guide was born. And one of the key features that stood out was the definition of active phase of labor, which shifted from 4 centimeters to 5 centimeters. Now, the labor care guide is actually not just a paper tool. It's actually a complete philosophical change in the way that labor is managed. It's not just the plotting. You realize there are very many recommendations, key amongst them being respectful maternity care, and that was incorporated, and it's actually the first part of the labor care guide, woman-centered care. And that is how we came up with the labor care guide. The problem is that these recommendations and this tool came out and were released during the height of COVID. So somehow it wasn't so much publicized until when COVID started to go down in the year 2022 or thereabout. Okay? So that's the story and how we've come from the WHO partograph. So the labor care guide is a real-time labor monitoring tool which replaced the partograph. It provides woman-centered care, emphasizing individualized, respectful care. Remember, the other one didn't even have anything like shared decision-making. And its primary aim was to reduce unnecessary interventions in labor, especially artificial rupture of membranes, oxytocin augmentation, and such, and only to do or perform such interventions when they are really necessary. So some of the studies that have been done have actually shown a significant reduction in cesarean section rates using the labor care guide, as one of the studies that was done by Pandey et al. And published in the American Journal of Obstetrics and Gynecology in 2022, and Vogel et al. So what are our study objectives and rationale? We wanted to evaluate the impact of implementing the WHO labor care guide on emergency cesarean sections, at St. Francis Hospital Nsambya, which is a low-resource tertiary health facility in Uganda. It's one of the largest tertiary health facilities. Our secondary objectives were to compare social demographic and obstetric characteristics of women who are monitored using the partograph and later by the labor care guide, and look at the maternal complications after delivery across the two groups, and compare immediate newborn outcomes between the two groups, and finally use an ITS to detect the level, the slope change, pre and post labor care guide introduction. So the study design, it was an interrupted time series study, which was done by retrospective review of medical records, and we used linear segmental regression analysis to come up with conclusion. Now, why we used an interrupted time series, just as a minor explanation, this is a quasi-experimental studies. The true experimental studies are actually randomized control trials, and they have three key components. We have a study group, a control group, an intervention, and most importantly, randomization. The problem is sometimes you may not be able to randomize patients for one reason or the other, and that's how we come up with a quasi-experimental study group. The strongest amongst the quasi-experimental studies is the interrupted time series. The others are the pre- and post-test series, like what had been shown earlier. So the setting was St. Francis Hospital Nsambya, as I'd mentioned. It has two labor wards. That's the Ops and Gyne department. The data was collected between June and September of 2023. That was 4 months of data extraction, but the data was spanned from mothers who had been monitored from July 2021 to June 30th, 2023. The pre-intervention period was when mothers were monitored using the WHO partograph. That was from 2021 to 2022. That is when the labor care guide was adopted from 1st of July. So that is when now we took it up as the post-intervention group, though there was a 3-month period that we gave for the exchange. So the hospital conducts an approximate 300 deliveries per month, translating to 3,600 deliveries per year. So I hope we've understood that bit here. The study was from July 2021 to June 30th, 2023. However, the WHO labor care guide was used to monitor labor between 2021 and June 30th, 2022. From July 1st, 2022, up to the end of the study, which was 2023, the labor care guide had been adopted as the labor monitoring tool of choice. So our study flowchart, we had a total of 2,662 women who were included in the study. We excluded 211 because they missed critical parts of the documentation. So finally, we ended up with 2,451, something that I forgot to mention. It was a census study, so we included all women who were monitored in labor. The partograph group had 1,260 women. That's from July 2021 to June 2022, whereas the labor care guide had 1,191 women. That was from July 2022 to July 1st, 2022 to June 2023, and those were the characteristics that we looked at. So our results, the socio-demographic characteristics were basically the same. There was no difference between the two groups in terms of maternal age, religion, education, and other factors. So no p-value was above 0.05. You're moving it from your side. Okay. So about obstetric and clinical characteristics, the mean gestational age was 39 weeks. Preterm deliveries were around 3% of the study population. Majority were multiparous. HIV positivity was around 3%. Hypertensive disorders in pregnancy were around 10%. Hyperglycemia in pregnancy was around 2%. Yeah. Now, about the mode of delivery, because this was a key comparison, from the partograph group, those who delivered via vaginal birth were 70%, whereas those who had emergency cesarean section were 29%, 29.3%. Whereas in the labor care guide group, the vaginal births, those who had vaginal births were 84%, whereas those who delivered via emergency cesarean section were 15%. So there was a 14% risk reduction in emergency cesarean section rates. The p-value was 0.001, which was significant. So both had comparable obstetrics and clinical characteristics except the mode of delivery. So about the interrupted time series study, as I'd said, we normally look at the slope pre-intervention. The most important thing being the level change immediately after introduction of the intervention, and then the slope post-intervention. So pre-intervention, we already seeing a regression coefficient of negative 0.071 with a p-value of 0.03, which means even before the introduction of the labor care guide, there was a slow but significant decrease in emergency cesarean section rate before we introduced the labor care guide. So regression coefficients usually range from 0 to 1. If it's 1, that is a perfect relationship. If it's a negative, it's a perfect negative relationship. If it's a +1, it's a perfect positive relationship. If it's 0, there is no association. So that's how they interpreted. Now the level change immediately after introduction of the labor care guide, the regression coefficient was 0.80, negative 0.80, with a p-value of 0.016. The 95% confidence interval was 0.014 to 2.014. So there was a significant immediate drop in emergency cesarean section rates after the labor care guide adoption. The slope change post labor care guide was, the regression coefficient was 0.015 with a p-value of 0.053. So it was not statistically significant, though we see that there was a sustained benefit over time. About the aggregated data, there was a 29.4% emergency cesarean section rates in the partograph group, 15.4% in the labor care guide group, with a 14% risk difference, an odds ratio of 0.44, with a 95% confidence interval of 0.036 to 0.053. That means those who are monitored using the labor care guide had a 56% less risk of undergoing emergency cesarean section, lower odds as compared to those who are monitored using the partograph. So this is a graphical representation of the same, the regression. We can see the slope that was there during the partograph group. There was already a slow decline. Then the change in trend is easily visible. I don't have a pointer. It would have been very easy to, let me see. I hope this is visible. So this was the trend pre-intervention. This is the regression lines. Each blue dot here represents the observed values at each month. So from the time we introduced, we were doing the values monthly. This is the pre-intervention trend. We can clearly see the slope change. Then this is where we introduced the intervention, the level change from expected to what we got, and this is the counterfactual, the dotted line. So clearly we can see there was a drop and it was sustained over the period that we did the study. So maternal complications, we can see the maternal complications, postpartum hemorrhage, admission to HDU, ICU, and maternal deaths. We had 130 during, in the total period, 33 and 3. Partograph, 66, PPH prevalence, the other one was 64, which was not statistically significant, p-value was 0.56. Admission to high dependency unit were 20 during the partograph period, 13 during the labor care guide with a p-value of 0.86. Maternal deaths, there were 3. 2 during the partograph period, 1 during the labor care guide monitoring. Again, they were not statistically significant when it comes to newborn outcomes, the live birth and the stillbirth rates. So we had 3 fresh stillbirths during the partograph group monitoring. One during the partograph group and 2 during the labor care guide group. And macerated stillbirths were 6 and 1. So again, they were not statistically significant. So to our discussion, from what we see, there was an immediate significant decrease in emergency cesarean section rates with a level change of negative 0.0880, with a p-value of 0.016 following adoption of the labor care guide, which is consistent with evidence from India, as had been shown by Pandey et al. In 2022. Post-introduction of the intervention, there was a sustained benefit. There was no significant slope change post-labor care guide introduction, indicating a sustained effect. So if the slope had then gone up, we would say it wasn't really significant. We didn't have any worsening of outcomes, and we see that it's the labor care guide real-time prompts reduces unnecessary interventions, particularly ARM and oxytocin augmentation. I didn't display them there. So this aligns with the WHO intrapartum care guidelines, and it's recommended as a policy tool, not only for Uganda, but other countries. And it's good that our country is headed towards that side. Now, the strengths and the limitations. This was a robust quasi-experimental approach, which allows for graphical representation of data and assessment of both intended and unintended consequences when you're doing the regression analysis. We had a large sample of 2,451 participants over 2 years, which provided sufficient power. And we had at least 100 individuals per time point, which exceeds the recommended minimum for ITS, which is around 10. It was conducted at a tertiary hospital. And we had two comparable groups with similar baseline characteristics. Now, some of the limitations is that the most important is we had no randomization, so it's very hard to say that it's the only factor that led to the decline in cesarean section rates. So you can't control for very many confounders if you don't have randomization. So it's very hard to bring around issues of causation. We didn't control for autocorrelation and seasonality. Now, this is something very important when you're doing an interrupted time series and time series in general, because either way, we know there are seasons and things change according to seasons. Like, for instance, in our facility, it's primarily managed by residents, that is senior registrars and interns, and they keep changing. So the patterns that have been observed before are that there are changes and variations in the rates of cesarean section based on when interns are posted, when the new groups of registrars come in, the change in the nursing staff, and other factors that we could not be able to control about. So seasonality is basically almost similar to autocorrelation, but seasonality is a pattern that you expect, but autocorrelation is a pattern that may not be very predictable. Usually you use the Dubbin-Watson tool to take care of that, but we were unable to do it because of the costs associated with doing that analysis. Again, about validity, that requires the labor care guide to be the only intervention that changed during the study period. That can be assumed, but we cannot fully guarantee that it is the only thing that changed. The human behavior plays a big role when it comes to ITS studies. Again, it was a single center study conducted in Uganda, and again, it's primarily run by registrars and, of course, under guidance of the consultants and interns, and it may not be generalizable to all the facilities. One of the things that I strongly believe, and I probably think that is a question that would come, is I think these observations were mainly due to Hawthorne effect. For those who understand Hawthorne effect, because someone is observing you, you change your behavior, okay? It may not necessarily be because of the labor care guide. That's why we'll have some recommendations around, because remember I told you this study was actually conducted, the BOLD study was conducted in that facility. So they already knew what they were expecting in terms of the labor care guide, okay? The seniors were on us, they were observing what we were doing. So it may actually be due to the Hawthorne effect, and maybe by now the cesarean section rates are already back to how they were before. Okay. So, as we've seen, it accounted for that 14% risk difference with no statistically significant difference between those two groups. So Labour Care Guide is a low-cost, evidence-based tool promoting individualized, woman-centered care, respectful care, aligned with WHO intrapartum care guidelines. And we recommend its adoption as a policy tool in intrapartum care across the whole world because it's designed for all settings, both high and low middle income setting. And one of the things that probably I forgot to write there is we probably need to, okay, of course, one has been done. We need a randomized control trial, probably a multi-country randomized control trial to actually assess its effect on reduction in urgent Caesarean section rate. But remember, that was not the only aim of the Labour Care Guide. Thank you very much.